Um, Good morning and welcome to the RIAC Learning Series. My name is Vanessa Brewer. I am the Regional Interagency Council Program Administrator. My co-host is Lee Taylor. She is the State Interagency Council Program Administrator, and we both work at the Department for Behavioral Health, Developmental, and Intellectual Disabilities. As a reminder, RIAC Learning Series sessions have been scheduled for January through June 2022, so you can see that on the screen. Information for monthly sessions as well as the registration link for each is provided on the flyer, and anyone is welcome to attend these sessions. So please feel free to share the RIAC Learning Series flyer with anyone that you think that could benefit from these sessions. I'm going to go ahead and stop sharing my screen. Let's see. Maybe I'm going to stop. There we go. Oh, hold on just a second. All right, so our presentation today is titled Families First Prevention or Family First Prevention Services Act in Kentucky. Our speaker is Lena Morehead. Lena is a graduate of Spalding University in Louisville, Kentucky with a master's degree in social work. She obtained her master's degree in social work in 2007, and she's been employed with the Cabinet for Health and Family Services since 2005 and has held various positions within the cabinet. She is currently in the prevention branch as a Family First specialist, and she also is an adjunct instructor for Campbellsville University at the Carver School of Social Work. She has been with the Carver School of Social Work for 5 years, teaching online field education, practicum foundation classes. She is happily married with 2 adult children and 4 grandchildren, and she also enjoys teaching gardening, traveling. She also enjoys teaching, gardening, traveling, and volunteering for nonprofit groups. Before I turn it over to Lena, I wanted to share a few housekeeping items. If you haven't already, please mute your mics. This workshop will be recorded and posted on the RIAC webpage, and we will put the link to the webpage in the chat box. You may use the chat box for questions and or comments, and Lee and I are both going to be monitoring it during the session, and we will address those questions at the end of the session. And speaking of which, today, not only do we have some time carved out for question and answers, but we also have some time carved out for brainstorming on how RIAC and system of care partners can get involved with Families First, how we can encourage families to participate in Families First Prevention Services Act services and assist with identifying current gaps and or needs. Lee has graciously offered to be our scribe as we brainstorm together so that we can send everyone in the audience home with ideas that you all can come up with in hopes of being able to further explore by your RIAC and your agency. Also, a session evaluation link will be posted in the chat box towards the end of the session, so please take a moment to complete it. And as always, certificates of attendance are available upon request. So please email me if you would like to have one, and I'll put my email in the chat box. So please join me in welcoming Lena. I'm going to go ahead and turn it over to her.
Thank you. Good morning, everyone. I'm glad to be here. As Vanessa stated, I am Lena Morehead, and I'm with the Family First Social. I am the Family First Social Service Specialist on the prevention branch. Today, I will go over with you the Family First Prevention Service Act overview, the candidacy population, the Family First Prevention Service Act programs in Kentucky, the state fiscal year 21 programmatic outcomes, the Kentucky State Plan and Amendments, evidence-based practices, CQI activities, and FFPSA and RIAC intersectionality. The outcomes, the objectives for this presentation, the participants will gain knowledge of the federal law and opportunities provided by the law for Kentucky. Participants will be able to identify FFPSA programs in Kentucky, including population served and geographic availability. participants will gain knowledge of 8 evidence-based practices federally approved for use in efforts to further service provisions. FFPSA, which is the acronym for the Family First Prevention Service Act, is the most significant child welfare law in the last 20 years. Historically, Title 40 funds were only available for children in foster care through the foster care maintenance payments. FFPSA dramatically alters the federal financing structure to allow partial reimbursement for prevention services beyond the waivers for all states and prevention services with requirements for income and poverty guidelines not required. This provides Kentucky a tremendous opportunity to fund prevention services, which have historically been underfunded. The spirit of the Family First is that children thrive best and deserve to be in a family-like setting when removal is necessary, and this is possible. There are times when youth require a residential type setting. The Act acknowledged this and put requirements in place to ensure the need is clearly identified and that family engagement and transitioning to a family setting when appropriate is a primary focus. There are multiple acts, requirements, and provisions. I am going to go into further detail on some of these in the next slides. Some of the major ones include there are no income requirements or tests required for service recipients. The services can be funded up to 12 months or longer with redeterminations. States must identify and define candidates for foster care and create a child specific prevention plan. Services and EBPs must be delivered through trauma-informed approach. There are specific EBP ratings and category requirements, CQI and research evaluations, and a requirement for states to receive an approved state plan spanning 5 years from our federal partners. The theory of change and logic model outputs FFPSA goals in Kentucky are decreased entries, re-entries into out-of-home care, decreased maltreatment and repeat maltreatment, decreased caseloads, decreased out-of-home care expenditures, and to increase child and family well-being and increase investments in prevention spending. It is important to note that foster care is still a necessary intervention at times. But what we are striving for is a system where foster care is not the primary source of intervention due to the lack of prevention supports for families. Whenever possible and safe, our goal is to strengthen families from the inside out versus a family in spirit experiencing the trauma of removal as a primary intervention, then working to reunify. The safety of children continues to be our #1 priority. Our assessment of safety, risk, and protective capacities that impact decisions was not changed as a result of the Family First implementation. All of prevention services I will discuss today exist prior to Family First implementation. FPP for decades, START for over a decade, and K-STEP for 5 years now, with the same high success rates they have now. What Family First changes is the stagnant and limited funding for prevention services, which allow us to move towards meeting a need we have historically not had the capacity to meet. And then Family First also afford us the opportunity for clinical enhancements with implementation of rigorous and highly rated EBPs. Candidates for foster care are children eligible for Family First prevention services. They include children or cases where substantiation of maltreatment exists, along with the ongoing DCBS case, and safety or risk factors can be mitigated by providing in-home services. Cases where maltreatment is not substantiated and a family in need of services, an ongoing case is open and services are provided to mitigate maltreatment from happening. Prior to Family First, tertiary prevention services was limited to cases with a substantiation. So this population in the candidacy definition allows to serve families and prevent maltreatment before it occurs. A child who has recently been reunified for whom services to families will mitigate identified risks, preventing further maltreatment and re-entry into out-of-home care. The pregnancy and parenting youth, which you will hear me say PPY, are a population outlined in the Act as eligible. PPY are not candidates. They are automatically eligible for services when they are in out-of-home care and their child is living with them. Family First prevention services in Kentucky consist of family preservation and reunification services, FPRS, Kentucky Strengthening Ties and Empowering Parents, KSTEP, multisystemic therapy prevention pilots, and sobriety treatment and recovery team START. Here is the Family First prevention services by region. FPP and Family FPRS, which is Family Preservation Reunification Services, are available statewide. KSTEP is in the Northeast Service Region and Salt River Trail, soon to be in all counties in Salt River Trail, and soon to be in the Cumberland Service Region. START is available in 7 counties throughout the state: Kenton, Campbell, Boone in Northern Bluegrass, Jefferson County, Fayette County, Boyd County in Northeast, and Davis in 2 Rivers. The Family Preservation and Reunification Services consist of, the goal is to prevent out-of-home care placement and maintain children safely in their home. They facilitate reunification of children through safe and timely exits from out-of-home care. The eligibility is a child from 0 to 17 years of age, moderate to high-risk cases, minimum of 3 to 6 hour face-to-face a week, caseload limit to 6 families at a time for the worker, duration determined by the needs and EBPs used, 24/7 availability to families, flexibility to meet with families when convenient during time of need, and flexible support funding to support concrete needs. The FPP state fiscal year 21 data includes families served, 2,674, children served, 5,240, children at risk, 4,796, children who remained home at closure, 4,486, and children removed to out-of-home care was 310, and the percentage of children in the home at closure was at 94%. The FPP expands to several, for expansions, prevention funding remains stagnant for a long time. With the shift and reorientation around prevention, Kentucky expanded FPP statewide by the increments of 25% to serve additional families in March of 2019 and April of 2020, and is expected again this fiscal year. Increased funding was also used to build EBPs and workforce capacity. And we also doubled flexible funding this fiscal year to meet concrete needs of families to prevent removals, such as funding to pay rent and utilities and etc. Kentucky Strengthening and Empowering Parents K-STEP is an intensive in-home services and substance that provides substance use disorder treatment to address parental substance use that place children's safety at risk. Must have one child in the home under age 10 who is at moderate to imminent risk of removal. Parental substance abuse is a primary risk factor. The family has an investigative, not ongoing CPS case. The investigation will result in the case being open for ongoing services. The programs include quick access to services, to treatment, removal of financial barriers, and collaboration and joint decision-making. The duration of services is up to 8 months with extensions permitted beyond this as assessed by family progress and phase completion. Service intensity is 5 to 10 hours per week, 2 contacts a week, 1 child included, must be included for 2 to 5 months. 2 to 10 hours per month, 1 contact a week, must include children for 1 to 3 months. 1 to 8 hours per month, 1 contact a month, and must include children for 1 to 2 months. The caseload not to exceed 9 cases at a time, and the age limit is under 10 years of age. K-STEP state fiscal year 21 data includes families served 224, children served 447, children remaining in the home or with a relative at closure was 389, children removed to out-of-home care was 58, and the percentage of children in home or with a relative at closure was at 87%. K-STEP expansions include in July 2017, K-STEP was implemented in 4 counties in the Northeast service region. In July 2019, K-STEP expanded to 8 counties in Northeast service region. In May and June of 2020, K-STEP expanded to all 15 counties in the Northeast service region. May of 2021, expanded to the second service region in Franklin, Spencer, and Trimble counties in the Salt River service region, Trail service region. And expected the state fiscal year 22 expansions into all counties in the Salt River service region, Trail service region, and also in the Cumberland service region. START serves families with at least 1 child under 6 years of age who are involved in the child welfare system and have a parent with a substance use disorder. Families are at the center of treatment and part of the decision-making team doing treatment and case planning. START provide intensive substance use disorder recovery services. They provide coaching to help parents with parenting and life skills. Intensive child protective service case management is provided. And they provide group and family counseling for parents, children, and other family members. To be eligible for START services, must be a new referral, not an active case, substantiated finding or FFPSA, 1 child 0 to 5 in a home. Primary risk factors are parental substance abuse. Services last on the average of 14 months with no minimum requirement, no minimum duration. The caseloads not to exceed 15 cases at a time, and the child must be under 6 years of age. START state fiscal year 21 data includes families served, 459, children served, 797, children removed to out-of-home care was 88, children remaining in the home and with a relative was at 709 at closure. Percentage of children in the home or with a relative at 89%. Multi-systemic therapy pilot program. MST will serve youth that are 12 to 17 years of age with possible substance abuse issues who are at risk of out-of-home care placement due to antisocial and delinquent behaviors, or youth involved with the juvenile justice system. It involves intensive family and community-based treatment, multiple weekly visits between the therapist and family over an average time span of 3 to 5 months. Typically, the therapy is conducted in the client's home. The primary goal of treatment is to eliminate and significantly reduce the frequency and severity of the youth's referral behaviors. Empower parents with the skills and resources needed to independently address the inevitable difficulties that arise in raising children and adolescents, and to empower the youth to cope with family, peers, school, and neighborhood problems. DCBS partnered with the Home of the Innocents to ensure continuity of MST delivery in Jefferson and Salt River Trail service regions, beginning with state fiscal year 22. In December of 2021, a second MST pilot began in the Northern Bluegrass service region. Plans for a third pilot in the Southern Bluegrass region is in the works. The Family First Prevention Services combined outcomes for state fiscal year. The total families served for state fiscal year 21 was 3,357. Children served was 6,484. Children at risk was 6,040. Total children remaining in the home with a relative at closure of risk was 5,584. Total removed to out-of-home care was 456. And the percentage of children remaining in home with a relative at closure is at 92%. Here you can see a child welfare spending across 3 categories: prevention, out-of-home care, and adoption. Adoption includes expenses for both children still in care in pre-adoption placements and post-adoption expenses across 3 fiscal years. Since state fiscal year 19, we have invested nearly $10 million in additional fundings for prevention services, and out-of-home care costs have decreased a little over $58 million. It is hard to know what is correlated versus casual with so many factors, but we do know we implemented Family First 3 months into the state fiscal year 20. And in the same state fiscal year, you can start to see a shift. The public health emergency would have only affected the last 3 months of state fiscal year 20. And we are starting to see a real shift in our system. We also have primary and secondary prevention efforts that are bolstering in this fiscal year. I mentioned the 5-year state plan approval by the federal government. All states must implement FFPSA by October of 2021. Kentucky implemented in the first month it was possible, which was October of 2019. And Kentucky was also the 5th state to receive an approved state plan from our federal partners. The plan outlined our EBPs to be used of the 5-year period. and we can amend the plan to meet our needs over time as more interventions are approved on the Title IV clearinghouse. The Act also requires the use of evidence-based practice approved and rated on the federal Title IV clearinghouse. These EBPs must be approved on each state's 5-year plan. There are 3 categories for intervention: in-home skill-based parenting programs, substance abuse treatment and prevention, and mental health treatment. There are also 3 ratings allowable for use of the evidence practice for each EBPs: promising, supported, and well supported. There are ratings below this, but only promising or above are allowable. And then 50% of the state intervention must be delivered through a well-supported EBP. Here are the current approved EBPs in their respective categories approved on the Kentucky State Plan. For mental health is parent-child interaction therapy, PCIT, multisystemic therapy, MST, trauma-focused cognitive behavioral therapy, TFCBT, functional family therapy, FFT, and motivational interviewing, MI, and high fidelity wraparound. For substance abuse is START, motivational interviewing, MST, and high fidelity wraparound. For in-home services, it consists of home builders, START, motivational interviewing, and high fidelity wraparound. Here is a visual representation of the EBP's availability throughout the state. TFCBT, home builders, and MI is available in every region. FFT and PCIT in nearly every region. MST in Jefferson, Salt River Trail, and Northern Bluegrass now, with planning for 1 additional region. START is in Jefferson, Fayette, Davis, Boyd, Boone, Campbell, and Kenton County across 5 regions. And just to give you an idea of where we started, this map shows the EBP availability in 2019. You can see several regions had 0 Title IV EBPs or only 1 or 2. Home builders were offered, but it was not offered by Fidelity to Fidelity at the time. PCIT was only offered by K-STEP providers in limited counties, and TFCBT had a very limited capacity. The state Title IV prevention plan amendments include the use of motivational interviewing in all 3 EBP categories for substance abuse, in-home skills-based parenting, mental health, the use of motivational interviewing by the child welfare workers, high fidelity wraparound to be approved for transitional claiming. The plan can be amended over time as new EBPs are approved by the Title IV Prevention Service Clearinghouse. The amendment was submitted on 12/23/20 and was approved on 12/10/21. For the plan's future and planned state plan amendment, we'll eventually submit K-STEP as a EBP for traditional claiming. K-STEP is rated as supported EBP based on the Title IV clearing rating criteria by the Public Consulting Group through an independent systematic review. An evaluation and manual has been completed and posted to the state prevention webpage, which is listed. The next amendment for inclusion has been drafted, and we will also expand definition for candidates for foster care to include children without an ongoing DCBS involvement. Research evaluations was required by the Act for TFCBT, START, and high fidelity wraparound due to the promising rating below the well-supported rating. University of Louisville is completing the START evaluation, and the Office of Data, Health, and Analytics is completing the evaluation required for TFCBT and high fidelity wraparound and the overall Family First implementation. An evaluation would also be required for case step conducted by the University of Kentucky once approved. The CQI process are required by the Act for well-supported EBPs, where evaluations requirements are waived. Kentucky completes CQI for all EBPs. So the CQI, we provide assessment or reach of services, assessments of DCBS and provider capacity, EBP, fidelity monitoring case reviews, and quarterly prevention CQI stakeholders meetings. The measurement framework. The measurement framework is for implementing and evaluating preventive services that help identify resources and metrics needed to successfully implement and evaluate child welfare preventive services, including evidence-based practices and those related to Family First. To measure the extent which preventive services are reaching children and families, being implemented with fidelity and achieve desired outcomes. And the framework suggests tracking measures in 4 areas: capacity, reach, fidelity, and outcome. Capacity measures the access to the degree to which the agency devoted the necessary resources to support implementation of preventive services. Reach measures related to children and families referred for services, outcomes of those referrals and services uptake and completion. Fidelity measures are measures that assess the degree to which the service was carried out with fidelity according to capacity, process, and quality requirement. Outcome measures that assess the impact of service on child and family outcomes. The agency capacity referred to the resources that agencies devote to broader work and staff to support implementation of preventive services. We have partnership with Chafin Hall to deliver surveys and focus group assessing capacity measures for DCBS and providers. So they worked with us on staffing and capacity to deliver EBPs, training and coaching needs, technology support, procedures, data systems, communication strategies, working with external stakeholders, role-specific measures, invoicing, claim and reimbursement, and fidelity monitoring activities. In October, a survey was delivered to DCBS staff. The survey ended in November of 2021. Responses are currently being analyzed now through quality assurance and Chafin Hall. A focus group will occur this month at our stakeholders meeting with our service providers and will be presented in our April stakeholders meeting. Here is an example of a REACH report. We have partnered with our state child welfare information system, CWIS, and quality assurance staff to build a dashboard to assess the reach of services through our eligible candidates. Those referred, service uptakes, and service completions, and reportable by region, age, gender, race, ethnicity, to access and respond to any disparity and disproportionality. So this is what our dashboard here will look like. Here is a mock version of what our REACH report will look like. You can see identification of potential candidates, those with substantiated or family needs of service findings, and an ongoing in-home case or pregnant and parenting youth, broken down by race and ethnicity. On this slide, we got potential candidates by age and gender. And then this slide shows how we capture information by regions and the percentages. Here we move into those eligible who were referred, again, by race, ethnicity, age, gender, and region. On this slide, we have how did the gatekeeper respond to each referral sent by the worker, assessing the referral disposition reasons to inform capacity needs. So we have this information through our prevention referral. This slide, and then the outcome if a child's receiving intervention, referred, or additional intervention to assist in identifying providers' capacity or training in EBPs to meet the need of children identified, or workers' clinical skills in selecting appropriate intervention. So this slide will provide that information. Was the right intervention recommended, and so forth. So for fidelity is the extent to which service is carried out with adherence to intended approach and can be accessed by measuring the degree to which capacity, process, and quality requirements are met. The measures in this section will vary for each service or EBP the agency is evaluating. So the EBP fidelity quotient collects data on capacity and contacts, which includes staffing and training. Does the staff have is licensed or have a certification, the qualifications, training, supervisor staff ratio, staff client ratio, coaching and supervision. Process and compliance. Is the client appropriate? What's the appropriateness of the client? Activities of service. How many times were the client seen? The intensity, the duration, the timeliness of the assessment and services. And then the quality and competence will be measured through interviews, surveys, and focus groups with clients and clinicians. This is a case review tool for motivational interviewing. I am a reviewer. I review cases for fidelity. So when I receive case materials from our providers, I look to see if the provider have the appropriate education. Does the provider have appropriate training? Is there appropriate supervision and movement towards proficiency in the MI skills? Does the supervisor have the supervisor completed advanced training or in advanced training? Are they using the clinical assessment tool, Mighty Missed AMIA? Coaching, are they providing coaching and supervision that are specific and detailed? Are the session notes, do they indicate supervisors supporting the provider in adhering to the model? Is the client for capacity, can't think right now, but another valid question, is the client appropriate for Title 4E? They must have a current substance use disorder diagnosis or relapse prevention, a deficit in daily living resulting from substance use disorder. Also, for activity services, are there appropriate assessment tools used to determine the base score and show progress? A provider must use either a ASAM, Dimension 4 Readiness for Change, or Eureka to assess the base score and stages of change of the client. The competent use of skills. Are they using the OR skills? OR skills are open-ended questions, affirmations, and reflection summaries. Is there consistency with the MI spirit based on partnership, acceptance, empathy, autonomy, affirmation, and compassion and vocation, and not confrontation, judgment, imposition, authority, criticism, indifference, or education? So I must look to see all of that is in the case review materials. And change talk is used. Were there goal settings in the documentation, pros and cons listed, values and scalings? At the end of my review, I must list some of the case review strengths that I saw in the case materials sent to me, and case review enhancement opportunities. What do I see? What did I not get that I can list as an enhancement of opportunities? A lot of times in the beginning, our providers did not use a clinical assessment tool because of cost, because of many reasons. So that would have been an opportunity of advancement that the provider would work towards obtaining a clinical assessment tool. The quarterly Family First CQI stakeholder meetings deliver fiscal year outcomes, deliver quarterly fidelity monitoring, case review outcomes, provides training, focus group, and group work. We have partnered with Dr. Brandy Kelly Pryor in the Department of Behavioral Health, Developmental and Intellectual Disabilities, and the System of Care 5 grant, through the System of Care 5 grant. We're working on assessments of design and implementation of FFPSA, strategies to integrate findings in the Family First CQI process, and ensure that FFPSA implementation is culturally responsive and does not create disproportionality in services. FFPSA and RIAC. The Family First FFPSA Act and the implementation in Kentucky shares the same philosophies as RIAC within the system of care, with expectations for care to be driven by child and family needs, to be trauma-informed, to be delivered in the child's community, and to be culturally responsive. There is intersection between our work with implementation of the System of Care 5 grant through partnership in the health and race equity assessment, and also through serving a similar target population with the System of Care 5 serving children birth to 21 years of age, who meets criteria for severe emotional disability with child welfare involvement, specifically with an investigative resulting in the substantiation of services need findings and the child remaining in their home, the same as our current candidacy definition. This work and interagency collaboration is so important for the population we are serving. Through our initial needs assessment and drafting our 4E state plan, we determined there were 27,522 children meeting our candidacy definition. And you can see from the serving numbers I presented that we are serving only a fourth of that, only a fifth in implementation. So we know even with services expansion and increased investment in prevention funding, And while not all families are eligible, all families eligible are appropriate for prevention services, a portion of our candidacy population needs are being met outside of DCBS contracted resources. This speaks directly to the necessity for collaboration and is ongoing to lead us into our closing exercise to brainstorm involvement, family engagement, and identifying gaps. Do you have any questions? And thank you for listening.
Lena, thank you so much for sharing this information with us today. I've attended several of the Families First Prevention Service Act, either webinars or trainings, and I learned something different each time that applies to the work that we do with RIACs. So I just want to thank you for that. Before we move into the brain